That the next panel will be Medicare for All. And Selma Makara, if she is here, will be the moderator for that panel. We know what Medicare for All and COVID, how COVID-19 could have been less prevalent had it not been for the fact that everybody doesn't have health insurance. So this panel, led by Salma Makar and Dr. Maureen Miller and Dr. Jay Brook, will discuss what needs to be done.
I'm sorry, Arthuretta, one of our panelists is unable to get on. He says that whenever he tries to get on, it asks him for his corporate account and a password. And I told him progress, and he hasn't been able to get on. Dr. J. Brock.
So what I'm going to do is, if you can send me privately in the chat, you go ahead and start your panel. You send me privately in the chat his email address, and I will send him a direct invite.
Okay. JD. So I told him to call in. Hopefully he's gonna do that. But if you could get him onto the Zoom, that would be even better. So hello everyone. Sorry for the slightly rocky start to this panel. This is the Medicare for All and COVID-19 panel. And today we're going to be hearing from 3 speakers, and then we're going to have a question and answer session. Our 3 wonderful panelists are Dr. Donna Armstrong, Dr. Maureen Miller, and Dr. Jay Brock. And who is now calling me because I guess it didn't work. And Dr. Jay Brock. I think we're going to start with Dr. Donna Armstrong. Dr. Donna Armstrong is Professor Emeritus of Epidemiology at the University of Albany, New York, and taught at the School of Public Health for 16 years, and is now working on sustainability and food security. Ms. Armstrong, are you with us? I saw you come in, so. Oh, sorry, you're muted. You have to unmute yourself.
Okay. There.
Okay, so we're going to start with each of the panelists giving us about 5 minutes, and then we're going to have a conversation and then take questions. Please put the questions in the chat, and please don't make them private, because then the person on stack, Michael Cobb, will not be able to see them.
You ready, Salma?
Yes, please go ahead.
Okay, first of all, thank you, Salma, for organizing this workshop. Thank you. I want to start by talking a little about the practice of epidemiology. Epidemiology is the science of describing how and why something like COVID, first of all, is higher in some states or counties compared with other areas. Number 2, why COVID is more dangerous for some groups of people, such as over 65-year-olds, or, for example, in African American or some Hispanic communities. Number 3, how and why are effects of COVID changing over time, especially trends in COVID deaths? Those are the common goals of epidemiology. But before any of these questions can be answered, the first question of an epidemiologist is, are the data reliable and being collected in the same way across states and over time? At the onset of the epidemic, the Centers for Disease Control and Prevention, CDC, established a standard definition for identifying a death caused by COVID, which is part of the role of CDC. But there is some evidence that some states may not be using this definition to assemble their state data. And this may be an effort to make COVID appear to be better or improving in their state by using a different definition of especially COVID deaths. An AP article this week describe numerous legitimate reasons for apparent COVID declines in some states, but the article never once mentioned possible differences between states in the quality of how data are being collected or changes in data collection over time. In my experience, public health has always been very political because it's a matter of life and death and quality of life for the public. But deliberately manipulating data, if this is occurring, is a violation of public trust, and this needs to be challenged. The second point that I would like to make up front relates to what is being called, quote, underlying health conditions, end quote, that cause individuals to be at higher risk of severe COVID illness. These conditions that are listed, for example, are heart disease, diabetes, asthma, cancer, immunocompromised individuals. But I want to suggest in today's panel that rather calling these conditions underlying health conditions, they should use the term underlying medical conditions. The reason I think this is important is that underlying health conditions include, for example, hunger. Hunger in the US right now is rapidly increasing at epidemic proportions, and hunger is an underlying health condition that puts people at risk of severe COVID illness. But because it's not an underlying medical condition, it's not being listed or discussed as a risk factor for severe COVID illness, and we're not responding to it. Currently, over 30 million people are unemployed, and home evictions and homelessness also is surging. To prevent severe COVID illness and reduce deaths from COVID going forward, we also need to address food security and homelessness in addition to medical care and, for example, availability of ventilators. So I think we need to recognize both underlying health conditions as well as underlying medical conditions and work to address both of these to reduce COVID deaths moving forward. That's all for now, Salma.
Thank you so much, Dr. Dr. Armstrong. We're now going to move over to Dr. Maureen Miller. Hi, so Dr. Maureen Miller is a pathologist and an epidemiologist from Fairfax County, my own CD10, who writes about healthcare and public health issues. She graduated from New York, the NYU School of Medicine and Harvard School of Public Health in 2014, and then completed pathology residency at NYU, where she worked in public and private academic hospitals and with the city medical examiner. After residency, she completed subspecialty training in blood donation and transfusion therapy at Emory University Hospital Network, including work at Grady Memorial Hospital and Children's Healthcare of Atlanta. Since 2009, she has been a member of Physicians for a National Health Program, including organizing with Occupy Wall Street and the Bernie Sanders campaign. She is also currently working on the virus, but we can't say more about it than that. So Dr. Maureen Miller, take it away.
Yeah, no, thanks, Alma. That was great. Unfortunately, I have to give a caveat at the beginning of this. I'm an employee of the federal government and working on the active response to COVID. So the material that I'll be covering today will be relating to things that have previously studied or things that are already published in the media, nothing else. It may unfortunately limit some of the scope of the questions, but I think there's still a lot to talk about even beyond that. So again, thanks for inviting me. When I was talking to Salma about setting up the panel too, we were talking about how the clinical experience of COVID, which I think is one that the public might be more familiar with from seeing the doctors with the masks on television from the front lines versus that of the epidemiologists who are also on the front lines, but they're doing much more work that's more unfamiliar to the public. I don't want to say it's more complex or more obscure. It's just, it's a different specialty. And I think Dr. Armstrong did a terrific job introducing like what the principles of epidemiology are in that. She made me think of a good reference to add to that too, but I'll put that in the chat after a bit. So Selma was saying before, like I'm a pathologist by training. When people think of pathologist, they're typically thinking of the person who performs the autopsy. the field is in fact much broader than that and much more diverse than that. But I remember feeling very at unease as a professional when COVID first started, because I was in a job where I was no longer doing that for a living. It just wasn't like I wasn't in a hospital. It wasn't part of what I was doing. So I was seeing trucks with like the fridges that they put up in New York City where I trained, and trying to imagine what the emotional experience of that must have been like while contending with this number side that Don Armstrong was talking about before, and then wondering, like, in some ways, which is the realer experience of COVID. And I think when we're talking about Medicare for all and about COVID, it becomes a moral issue. It becomes an issue of the heart. People like bring like emotionality to their activism when they can see people getting very sick and dying in front of them. The injustice just becomes very obvious. So I think Jay Brock, if he gets connected, is going to speak a lot more to the numbers, but I'll just hit some high points briefly, because I think a lot of the time people think about mitigating risk of getting COVID, which is basically what an epidemiologist does. And then a clinician does it, like when you've already got it, how do you mitigate the after effects of the disease that you've already contracted? So we can think about who's more likely to contract them such that they get worse disease. And worse disease are the ones who inevitably are going to need more healthcare, which leads to increased healthcare costs. So I'll also put this in the chat, but Physicians for a National Health Program has released a series of references combining epidemiology and clinical practice to figure out like who exactly is at risk for losing their insurance under this disease. I think I'm probably gonna I'm preaching to the choir for people to hear that like 45% of the US adult population has underinsurance in the first place. I'm sorry, I just saw the screen change, so I wasn't sure.
I don't know who did that. Sorry.
Yeah, it's okay. I was just curious. So basically, like, huge proportion of the American population underinsured or uninsured completely. And then you put into the mix COVID, where because of the stay-at-home orders, everybody's going into lockdown, which, like, in terms of the job losses, it's still a little bit iffy from some of the Department of Labor calculation, but something like 10 million people have lost their jobs. And if you think of the majority of the American population getting their healthcare from their job, that puts things into chaos. And their numbers don't even necessarily factor in the unemployed, or excuse me, the self-employed. Let me tell you this, so what happens when the self-employed then close down their business and become unemployed. So that 10 million people losing their jobs could be a vast underestimate of what's actually going on, creating a scramble on the markets now. I mean, it is possible to get COBRA coverage, to buy it yourself, to get a subsidized ACA plan if your state's on deadline. We're very lucky in Virginia to have Medicaid coverage with an expansion, but not all states do. And there's emerging research now from doctors saying that there's something like a 10% difference in people who are sufficiently covered for COVID in those who are in a Medicaid expansion state versus those who are not in a Medicaid expansion state, which obviously is going to create some very big problems down the line. We spoke a little bit already about what they call social epidemiology, so disparities in, say, African Americans getting this disease more than other groups, low income people, uninsured people. Very relevant to Virginia, there's a disparity in rural people versus urban residents getting it.
Right.
But just to wrap up at the end very briefly here, that I think the one that we don't think about as much as healthcare workers themselves. So healthcare workers are, as you guys know, a significant sector of the American economy. I think something like 1/6 of the economy, and they're bringing COVID back home to their families. And I mean, historically, especially coming from a state like Virginia with a really robust federal government employment, you think, well, then they're probably doing okay. I mean, they're heroes, they're risking their lives into this, but like, at least they're getting paid for it. When in fact, in many cases, that's not the case. They're making maybe a decent living, but at the doctor end, much less than you would probably think. And then especially on the burgeoning healthcare worker, and so like people who are working in nursing homes and nursing assistant positions, respiratory therapists who are the ones working in the ICUs on the cases all of the time, they may be living close to the poverty line depending on their job and depending on what region of the country that they're working in. So if the congressional relief programs aren't even funding those people to get increased insurance coverage again, then we're living in a country that we might not really be familiar with anymore. So it can be a little bit difficult as a physician to talk about these things openly. I mean, we do among ourselves, but then we live in a very money motivated healthcare system where there can be pressures from external administrative factors not to speak out about this. But the fact that you're seeing more of us speak up is a problem. And actually, this thing in the background, I don't know if you can see my screen. I put some notes up here, but I have a poster in the back. It's from the 1969 mayoral primary in New York City. And then the guy who ran for mayor on it, Norman Mailer, is a little bit problematic in many ways, but he and his co-running mate, Jimmy Breslin, who was a journalist in the city, made a very active social democratic campaign saying that we needed to have a robust social safety net to prevent these sorts of problems happening in the first place. That, I mean, Jimmy Breslin would have had a field day with watching like Bellevue Hospital in the last 2 months or so. But Breslin, during this campaign run, he was running against a centrist Democrat named John Lindsay, who was like a waspy, kind of like what became a Rockefeller Republican, but that doesn't really exist as much anymore, kind of like a Mitt Romney type, I guess. And so then Breslin, like criticizing Lindsay, says the city gets an imagination or the city dies. And when people were thinking about that, I don't think people were thinking about people actually dying. They were thinking about just like hyperbole, he's Irish, I'm Irish, like we like to be melodramatic. But I think that if anything is going to get the Democratic Party, whether a Biden or a Bernie supporter or a Warren supporter or elsewhere, toward Medicare for all, this has got to be it. This is like kind of like our last shot here. I mean, I know there's a lot of passion toward it, but just the particular political calculus right now, like the fact that the doctors are coming out to defend the need for the policy because of the COVID context is very unusual in American history and may not be replicated for a while. So anyway, I'll turn it over to Jay, but thank you guys.
So next we have Dr. Jay Brock, a longtime single-payer activist. Since like before Bernie came on this, became really famous 5 years ago, Dr. Jay Brock has been advocating for single-payer for, 20 years now? Unfortunately, due to technical difficulties, we haven't been able to get him to join on Zoom, but he is here with us via phone. So Dr. Brock, do you want to give your 5-minute speech on what you would like to focus on, and then we can hand it over to the panel discussion?
Sure. And first of all, you can hear me okay?
Yep.
Yes, and again, we're so sorry that you're not able to be here.
No problem.
On video.
I'm glad to be able to participate here, and I thank you so much for the invitation to talk. Let me introduce myself briefly. I'm a family physician, now retired. I'm an American, and I had the opportunity to train in Montreal, Canada, at McGill University. I did all my medical training there, and after I finished training, they hired me to teach in the same family practice residency that I trained at, and I ended up as an assistant professor of family medicine on the full-time medical faculty at McGill. And then I came back to the United States, and I ran a solo practice here in Virginia for more than 3 decades. I'm a past president of the Fredericksburg Area Medical Society. So I've had a pretty good chance to work under both single payer and multiple payer systems and see what the drawbacks are and the positives are for both. I don't think there are very many positives for our current system here. And the reason is that our current system, our multiple payer system of health insurance, has failed to do the 2 things any good health insurance system worth its salt should be able to do. Number 1, to cover everyone, and number 2, to do it in an affordable fashion so that not only patients can afford it, but the nation can afford it. We spend $3.5 trillion every year in healthcare per person compared to an average of all the other world's industrial advanced nations. We spend about twice as much per person than they do. And we still manage to leave 30 million people without any health insurance. More now with the COVID, we leave another 55 million people on a good day before COVID who can't afford to use the insurance they have. What good is insurance that you can't afford to use? We have 500,000 medical bankruptcies every year, basically unheard of in other countries because people can't pay their medical bills here. And we have, according to the Yale School of Public Health, 68,000 people who die every year because they cannot afford to obtain timely medical care. The problem is structural. Of the $3.5 trillion we spend every year on healthcare, the system automatically wastes $750 billion of that $3.5 trillion to run the system. These are administrative, marketing, overhead, and profit costs. And studies have shown, we can go into that later with question and answers, that if we had a single payer type system like they have in Canada, like Bernie and Pramila Jayapal are proposing in Congress, that we could not only cover everyone, do it without any additional out-of-pocket costs where people make contributions based on their income the most affordable way possible, but we could save $450 billion to spend on other things if we wanted to, or just put in people's pocket if we had that single-payer system. The problem basically is that our current health insurance system is based primarily on a private for-profit health insurance industry. Now, the joke, it's not really a joke, it's true, but the joke I like to tell is that in Canada, their single-payer system is even more popular than hockey. And here in America, our multiple-payer system is about as popular as the telemarketing industry. And the reason for that is because in Canada, people know that the system puts their interests first. In America, we have a somewhat different system where the business model of the health insurance industry is to take as many of our healthcare dollars as possible and then spend as few of them on our healthcare as it can possibly get away with. It makes the health insurance industry basically a middleman that takes our money and gives us practically nothing in return. And their business model is based on their fiduciary responsibility, which is to obtain the biggest profit for their shareholders as possible. That puts the whole system in a very uncomfortable position where it's basically an irreconcilable conflict of interest for the health insurance industry to deny anybody care because it will interfere with their bottom line. So an incremental system won't work, and neither will the building on the Affordable Care Act. Senator Warner this morning talked about that was his approach. I know it's many other people's approach, but it's doomed to fail because it A, won't cover everyone, B, won't do it affordably unless we are prepared to spend another $750 billion into the medical care system in order to cover everyone. So I'm going to leave it there. If you have any questions, happy to answer. But basically, a Medicare for all is the way out, especially the COVID has proven that making health insurance dependent upon your ability to have a job is as crazy as it gets. That needs to be decoupled. And again, only Medicare for all, in my opinion, is the way to go. And I'll leave it there. Thank you.
So thank you to our three doctors for sharing all that amazing information from three different perspectives. I was wondering, so at this point, I'd really like to have a panel discussion and let all three of you, speak to one another. Was there anything that, before I ask my questions, was there anything that you guys wanted to bring up in discussion with one another that you noticed, in the others' intro, like in the part they spoke, or if you have a starting point for this conversation. So you're all three now unmuted, so if you guys want to go ahead, or if you would prefer, I could ask a question.
Well, I could add a couple of points. For me, the current system is basically consider yourself you're a passenger on a ship in the middle of the ocean. There are 300 people on board, and there are enough lifeboats for 300 people. There's provisions, there's food, there's water, there's shelter. The ship is sinking, and after the first 200 people are allowed on board the lifeboats, the system says, that's all. We can only accommodate 200 people. The other 100 people, you're on your own. So I think that's a crazy way to have any system work, and that's how our system works. And I think it has to change. And it's very hard in getting people's attention. And when you get their attention, it's very hard in getting them to to pay attention to what you're saying to change the system. I think I'd be happy to hear anybody else's suggestions on where to go from here, because the situation to me seems so self-evident as a provider of healthcare, as a consumer of healthcare. Anybody else has suggestions? I'd love to hear them.
So Dr. Armstrong or Dr. Miller, do either of you have anything to add to that?
Am I unmuted? I can't figure
Yes.
it.
Yes, so all three of you are unmuted so that so that we can have this panel discussion, so you can talk to each other directly and ask each other questions and have a conversation for the next few minutes, and then we'll take some questions from the audience.
I agree that it's incomprehensible why Medicare for All is a big debate other than the profit interests of the current system. It's not an area of specialty of mine. I'm a social epidemiologist. I'm primarily focused on the direction of the epidemic and trying to understand how to best help the public to understand what's happening regarding this epidemic, because there's an awful lot of, I wouldn't even call it misinformation so much as non-information out there about immunity and infectiousness, and it's been very minimalist to me. And of course, the press has a role in that.
Yeah, I think Donna makes a good point there. Actually, I can't speak to the numbers that are being released to the public, but the component that she's saying about the role of the press in the end, what Dr. Brock was saying before is that, like, doctors feel like they're telling, well, not just doctors, all healthcare workers are telling the same healthcare story to themselves all of the time, that even if there's not necessarily a consensus, although there's a majority of people who think it should be fixed one way, like we feel like you're just like on loop talking to one another. I think Jay had some good analogies about that, but I think it's very difficult for the public just because they're seeing so many people die at once. Like, I mean, if you say like a couple thousand a day, it just, like, even as a doctor, like, you'd have maybe a roster of like 20 people on your list, probably more now in any given round. Like, the idea of your entire list dying times like 10, that's just, or more than that, is just like mind-boggling. Yeah. And I think if you don't have that reference point as like somebody who doesn't work in that sector, it's really hard to understand. I mean, the cost arguments like are very well established at this point. I think there was a period, like even like 5 years ago, where there was a lot of back and forth about like the legitimacy of some of the like cost of the savings that you would get on cost of care if you had a Medicare for All style administration versus like another system that seemed to be going away just because like the like medical urgency of it has become so clear. And then what Donna was describing is the health factors, like the fact that economic inequality is so egregious and obvious that it's really hard not to know, even if you don't agree on what's right, you know something is wrong.
I have a question for Dr. Brock. I'm struck by the immense cost of all of this ICU care. And when does the bill come due on this? You know, there's a lot of people, will they receive bills that, I mean, how does that work? You know, when people show up in the emergency department, the norm used to be you receive care, and the bill was discussed later. How is that working?
I'm no expert, but my understanding from what I'm reading and hearing is that any costs associated with COVID will be picked up by the federal government. The irony, the insanity here is that if you go into the hospital and you have a COVID problem, it will be covered. If you go into the hospital for a heart attack or for an appendectomy, it won't be covered if you don't have insurance. The principle is there. that the government will step up as needed to pick up the bill. Why limit it? I don't know. It's the same thing as the proposal to cover more people by reducing the eligibility age for Medicare from 65 to 60, which really helps the insurance company, because the older the person is, the more likely they are to need the care. And that lets a huge segment of the potentially sick population off the hook of the for-profit insurance industry and puts it on the federal government. Why they can't do that with everybody, I don't know. But I think that the principle has now been established that the government is the person to step in as last resort to cover these kinds of costs. And I think that's an appropriate analogy, because it's clear that the free market has completely failed to handle the problems that we have with healthcare. And when the free market has failed and private enterprise can't do it, the entity of last resort to step in, rightly so, is the government. The government will step in when everybody else has failed. And I think that's the role of the government right now.
I just want to add quickly to what Jay said there, which I think is really, really good. But Virginia, as we know, expanded Medicaid, but a lot of states didn't. And then now, I mean, like, people watch Andrew Cuomo every day talking about New York, again, a state with a relatively good Medicaid program, but like, that states could potentially go bankrupt. Like, the states cannot afford to take on the burden of this, because there were talks of sort of a compromise solution during COVID, like, oh, people could give Medicaid like coverage done through the Medicaid system to cover the COVID expenses themselves. And then just like that's not going to be sustainable, is it?
Yeah, can I just jump in there? Yeah, the reason why, for me, when I look at single states doing it, we pay so much in federal taxes compared to what we pay in state taxes that it's really hard for even a wealthy state like California to enact its own single-payer system. The thing about the single-payer system is that the $750 billion I talked about that is wasted in costs that have nothing to do with giving anybody health care, that money, if it's actually spent on health care, there would be a surfeit of money left over at the end of the year. There's $450 billion that we could save every year in administrative, marketing, overhead, and profit costs in a single-payer system that can go to healthcare. And anything over that can do an awful lot. Help current healthcare workers who may lose their jobs have a soft landing. I would mention this with a quiet voice, that maybe you could even buy equity and buy out the insurance companies with that money that's saved. So about going bankrupt, the federal government doesn't go bankrupt because the federal government can print money. Also, under single payer, hospitals are given a global budget, works fine in Canada. When I go to hospitals in Canada to visit, they do fine, thank you, with a global budget that would cover those kinds of costs. And this, by the way, would be really good for hard-hit rural areas or areas in urban areas where there's not enough paying customers. The problem with certain hospitals going bankrupt isn't because they lack patients. They lack patients who have the ability to pay. That problem disappears under a single-payer system. So I'm not too worried about states going bankrupt, because I don't envision states handling this at all. This is a federal government problem, and it should be a federal government program, and it works fine in Canada. By the way, the Canadian system, they have 1/10 the size that we have. We spend more on healthcare than their entire GDP, and they still manage to have a very robust healthcare system where their providers do very well. Thank you.
So we only have 9 minutes left, and so we're going to turn it over to questions. If it's okay, I'm going to ask the first question, and then we're going Michael Cobb, who's been on Stack, is going to ask the rest of the questions. My first question is, I know it's kind of hard to know hypothetically, but has America suffered significantly, and is the fact that our COVID numbers seem to be worse than other developed countries in part due to the fact that we don't have Medicare for all, whereas other countries have universal health care? Like, I guess the main part of the question is, like, how would things have been different in terms of the spread and the numbers if we had Medicare for all, if there is any difference?
Yeah, I can start real quickly. What you said reminded me of what Donna was talking about. The U.S., I think, compared to other, like what you're referring to as developed nations, the U.S. population in general is sicker. Like, it might not necessarily be of the same diseases as other places, but I mean, we talk about like prevalence of like behavioral diseases or lifestyle-based diseases like obesity, diabetes, renal failure, things like kidney failure, stuff like that, which potentially related. There are a lot of issues around that too, in terms of like epidemiologic analysis about like what should, as Donna was saying, what should be considered a medical disease versus what should be considered like an economic, like socioeconomic factor. But I think that's certainly one thing that's playing in terms of healthcare administration. Again, like, I'm not an expert, it's harder to speak to, but ours is definitely different than in other places.
Did Dr. Armstrong or Dr. Brock want to jump in on that?
One of my thoughts about having guaranteed medical care is that it presumably would give physicians the opportunity to do more preventive care. And it would also address the comment that Dr. Miller made in the beginning about the urban-rural disparity in medical coverage. You know, rural hospitals have been closing for decades back. But this ability to address prevention is really fundamental in public health. And my experience of physicians is they are chronically frustrated with their lack of time and ability to address prevention with patients. And so this isn't just a treatment payment issue, it's also a public health prevention care issue, which would allow our medical system to be doing more, giving people a lot more help in how to be healthier and prevent getting seriously ill, which it may very well be contributing to severe COVID illness, although I don't think the data is good enough to evaluate that at this stage. Thank you.
Yeah, those are really great, powerful statements. I completely agree. I think if nothing else, the COVID disaster that we have right now just shows that we are not prepared as a nation. We don't have the healthy enough patients. I think that's a great point, and that we need to take the financial worry out of healthcare. It's tough enough when you're sick. If you have to worry about going bankrupt or spending your life savings on medical care, we're barking up the wrong tree with our current system here.
Yeah.
Thank you all so much for answering that question. And now I'm going to turn it over to Michael Kopp, who has been collecting questions from the chat. Michael, what is our first question for the panelists?
Sure. The first question that we have, a couple of people have asked variants on it. Rashad Pearson asked it first, and it's a two-parter about Medicare for all. Number one is, would Medicare for all negatively affect a large amount of doctors' pay? And part B is, how would it affect things such as jobs for healthcare workers, pharmaceuticals, and then quality of care, quality of medication, medical technology, and the like?
I guess I should answer that one. Those are great questions. You could spend a lot of time talking about that. In Canada, where they don't spend that much on healthcare compared to what we do in terms of their GDP, doctors are paid very well. Providers are paid very well. Hospitals do well. There is a disparity in pay right now in our country where some specialists, especially super specialists, get paid probably an inordinate amount of money. I think there's a need that is seen out there to increase the reimbursement for primary care doctors. So I think that's inevitable no matter what system that you have. In terms of other quality care parameters, we're not changing how we deliver healthcare in America with the Medicare for All. We have a healthcare delivery system that is rightfully the envy of the world. We are changing how we fund and pay for that care, not how we deliver that care. And so I think that that the good thing about a single payer system is that with a single entity, unlike our current system, something or somebody is in charge. Somebody takes responsibility. If there's a problem, let's fix it. Right now, the free market is supposed to do that and has failed utterly. Anybody else have any other ideas?
So thank you for that very in-depth answer, Dr. Brock. Michael, what is the second question?
Sure. The next question I'll put out is from Greg Brandon, who's asking about the intersection of epidemiology and virology, if we could speak to that.
Actually,
Dr. Miller. Yeah, that's pathologist. You can answer that to start.
a little different specialty, but yeah, we'll try. I mean, you're right. A lot of the epidemiology that we've been talking about today is what's called social epidemiology. It's like a separate discipline from infectious diseases epidemiology. There's overlap to it, but like when I think when people classically think of what an epidemiologist does, they think of like, oh, cholera in London or Ebola in West Africa or something like that. They're thinking of an infectious process. So like Ebola, for example, would be use of virology in public health. That I mean, this is kind of like a parallel issue, but I think a lot of what's been going on now also has to do with questions of how like public health organizations should be using advances in molecular microbiology to like identify what viruses are, how genetic sequences of viruses are different, because if they match in one place and another, like you're making an epidemiologic link between two cases. And I mean, they're certainly important. I would say that like virology and epidemiology is the classic thing, but I think more what we were talking about today is like how people use like metaphors of contagion to like stigmatize populations, if that makes sense, to say like some people don't deserve healthcare as much as others because like they were in the neighborhood that just happened to get this. I don't know if I'm explaining that very well, but like anytime you're trying to make an equitable healthcare system where everybody gets covered, we should believe that like everybody is equally entitled to the same level of care. And I think sometimes people will like use virologic findings to like move the epi a certain way to like advance certain health policies. I'll have to remain vague, but that's all I'll say.
So thank you so much. Michael, if you could ask the third and last question, and then that's going to wrap up our workshop here today, and it's then going to move on to the How Do You Pay For It MMT workshop. So Michael, with the third and last question, and thank you to all the doctors and all of the attendees and everyone in the chat.
Certainly. This is a tough one to ask with so little time remaining. It was asked by Lillian Brooks, which is, what is better about Medicaid for all as opposed to universal health with a public/private option? VP Biden talks about fixing the ACA. Why not do that?
Sure, I'll answer that. The ACA is built on our current multiple payer system. It necessitates wasting $750 billion a year cost to run the system. If you don't eliminate that $750 billion, we don't get to cover everybody. We don't do it affordably. The current system has to go. Basically, building on the ACA means we have incremental change that doesn't cover everyone. It's a little bit like asking people from some decades ago that to be satisfied with reducing but not eliminating the poll tax. And I think that's basically absolutely the wrong way to go. We can't build on the ACA. I'd love to have a talk with anybody, Vice President Biden or Mark Warner, anybody else up to this effect, because you have to consider the $750 billion the current system wastes. As long as we perpetuate the current system, we will need to account for the fact that we're wasting that money and not being able to cover everybody affordably.
If any, did any of the other doctors want to jump in on this, or otherwise we'll wrap up?
I'll make a very quick comment that came up previously, and that is about the enormous unemployment, which by all predictions, is not going to be V-shaped here. Our economy is not going to simply come back. And we have an enormous number of people now who have been thrown out of medical insurance because they are unemployed. And that is compounding the limitations of ACA, I think.
Here, here.
Agree.
Okay, so with that and with 2 minutes delay, I apologize, Poti. We're going to turn it over to the next workshop. Thank you so much to all our doctors. Thank you so much to all the attendees. I'm sorry we couldn't get to all your questions. I mean, we could do this workshop for 2 hours, but for now, we're going to turn it over to Poti's very interesting MMT workshop, Modern Monetary Theory. Poti, do you want to take it away?
Thank you, Salma.
Sure. Thank you so much, Selma, and thank you to the previous speakers for setting us up to connect what we just heard with our opening panel. I'm pleased today to be introducing my fellow panelists. Those are Lacey Watson and Fadl Kaboub. Lacey Watson has scored a historic primary win in our neighboring state of West Virginia. If Lacey, an MMT candidate from the start, scores a win in November, he will be the first African American representing the state of West Virginia in the 3rd district, but for the entire state. Fadl Kaboub, who is a professor at Denison University, is a leading expert on MMT, and as the president of the Global Institute for Sustainable Prosperity, is about as close, I think, as we can get to the heart of the Green New Deal as carried forward by Alexandria Ocasio-Cortez and the Bernie 2020 platform. I am Panayotis Yannakouros, a research scholar at the Global Institute for Sustainable Prosperity, and will introduce our panel with an overview of MMT based on my interactive workshops. So Ronald Reagan's counterpart, Margaret Thatcher, said, "The problem with socialism is that eventually you run out of other people's money." We can't really be progressives if we take this bait. If we do, our bold progressive programs fail. When they fail, we can blame the Republicans for not cutting the defense budget or not raising taxes to pay for it, and they'll gladly take the blame and keep winning elections while we die of despair. Today, I'll tell you how to pay for it and why that's the wrong question. Imagine, for clarifying some concepts, that we are in a magical realm with a drawbridge outside your door, so you cannot leave your home unless you get one of these flyers that I have handy here. In my workshops, people gladly hand over imaginary food and services for them. They are valuable, and I have unlimited ability to issue them. But my power isn't unlimited. If I run out of things to buy, I can keep issuing more permissions, but I'll not get any more things. I'll just see prices starting to run up, known as inflation. Imagine now that you can go freely, you can come and go freely, but your grocer or your doctor all have these debts. Most people will still work to get one of these pieces of paper, and once they have it, which we call a negotiable instrument, they'll give it to someone who needs it in exchange for something they need. And when they do that, the world turns upside down, because in that step, they monetized their society when that negotiable instrument changes hands and transfers economic goods. This is so important that I printed up on a cheat sheet for them to remember what they've done. So here's the cheat sheet. It has the face of the sovereign on it. And next to his face, we have 2 lines that will transport the person back to what they just experienced. And if you know what is on one of those bills, you know that it says this note is legal tender for all debts public. But note what we just did here. That line, which reminds us of the exercise we just did here, making a piece of paper valuable just by virtue of the power of the ruler, is written on the national currency of the United States. So this is the setting up of the undoing of Margaret Thatcher, because anything we derive from this, also applies to our currency. One thing that follows directly from this is that we cannot run out of money. Now, imagine that you have earned a stash of these permissions, and that I take just one away from you in taxes so that you can go free, and you walk out across the drawbridge with some extra in your pocket. Think about how you're feeling about that extra in your pocket. So I'm going to give us 3 definitions, and the first definition is going to be that thing that you're probably feeling good about in your pocket. That is the federal budget deficit. Now, you might decide that you want to keep that stash of material safe. You could put it in a special savings account that your bank has access to at the Federal Reserve. We call that a treasury security. And the piled up stockpile of these permissions and safekeeping that have not yet been used to pay taxes is definition number 2, the national debt. Even less scary than the deficit, because the deficit we could have run up accumulating, hitting our boundaries and getting inflation. We could have spent it inequitably and disturbing peace in our society, but once it's spent, it's water under the bridge. Not scary at all. The third definition that I'll give you is a negative number. Imagine now that you don't have anything and it's a new fiscal year, and I impose liabilities on all of you, so you have to scramble to get these permissions, and Tommy LeBeau gets it. And he turns in his taxes and goes out for a walk. Now you still owe. Are you willing to work, go to the grocer, and not to buy fruit, but to offer your labor? And the grocer doesn't have any permissions either. The state you're in now is definition number 3, unemployment. And putting it this way, you can see that unemployment is not your fault. As Brianna Joy Gray said in a nice little clip, it is a policy choice by the currency issuer. For some perspective then on the rhetoric of debt, taxpayers, and labor, I'll do a little bit of history. Another thing that you should have noticed here is, as we were doing this rather rapidly, I was spending as the sovereign, and then as you were getting ready to leave, I was taking back taxes. Now, if we looked at how our payment system worked, what we would see is that these tax receipts cancel out against your tax liability. If we did it on a spreadsheet, it would be like a positive 5 if you paid $5 in taxes and a negative 5 in your liability. Put them together, they cancel, turn into a 0. Can your taxpayer dollar pay for anything? If you just saw it vanish into a 0, clearly it can't. So several things that we have strong intuitions about, if we just follow some simple logic, appear not to be well-founded. So where do we get that emotional loading? For that, I'll try to share my screen and do a little bit of Virginia history for you. Okay, so here we see the quote from Margaret Thatcher. And here we see some terrible things that happened on this soil. Some people who had violent control of this soil had the idea that they could circulate a currency as well, and they were more direct on their bills. They said receivable in payment of taxes. Fortunately, we defeated them, and as they were losing their power, they were not very happy about the change in conditions. Now, they had accumulated here in Virginia quite a big currency user debt, which is different from our national debt, because they had tried to build new infrastructure because they had exhausted their soil through something terrible that they had done, which was using enslaved labor to grow crops. And once the people who had been enslaved won their freedom in that war, the planters insisted that unless they resorted to the overseer, the whip, and the hounds, their estates would deteriorate and never recover. Planters resented that emancipation not only challenged their sense of racial supremacy, but also eroded their authority as employers of labor. So why are we so cruel to our labor? There are some deep roots here. And what about their attitudes toward debt and this notion of the taxpayer? Well, here in Virginia, we had both a fiscal crisis from the point of view of the currency using state that we heard about from the medical doctors, for example, and there was a nationwide depression going on. And the conservatives were still in charge. And what they did in this debt crisis, they cut the schools that had been newly established. Well, what happened when they cut the schools is that the people who had been newly enfranchised got together, and with their votes, they took the state. Now, the planter class was not ready for this. They did not believe that this could ever be possible. And this is how they were feeling in the midst of what we called the Readjuster Coalition's rule. They threw up their hands and said at that point, it is not about the debt. It is not the debt question, but a struggle between conservative Democrats on one side for supremacy, note the word, of a good and safe government, and the worst political combination ever brought into coalition in Virginia on the other. What are they talking about here? Well, we're doing etymology here. They said, our hard-working, industrious, thriving people. Where have we heard that dog whistle? Well, they didn't dog whistle back here. They're going to make it explicit. Will never consent to allow the worthless class to determine what amount of taxes they shall pay. So you start to see the taxpayer meme emerging. Taking it another step forward, we shall not see our state placed in the hands of non-property holders, non-tax-paying people. And what sort of people are they talking about? I told you they're not going to mince words. It is a fight between the Anglo-Saxon and the African. So next time you think about using the term taxpayer dollar, think about this etymology. Think about that it doesn't make sense to begin with. And think about that the emotional loading goes back to something very ugly in our history. And I would offer you an alternative word, public money, public dollars. And that's where the real action is. The real action is when we get to the federal level, and I will quickly wrap it up. Because the way we pay for things at the federal level is not by recirculating the sovereign's currency. We issue permissions here in the United States according to the Constitution, which puts that power in the hands of Congress, specifically the House of Representatives. And what that is that we, with our little hands, send forward a representative, and then those representatives sit together in Congress, and they are presented engineering specifications of things we'd like to do and how it's done. Now, if they vote to pass that bill, at the bottom of the bill is a number that says how much it will cost. And the way they pay for it is they communicate the number to the Treasury, which communicates it to the Federal Reserve, which credits the appropriate accounts. That's all there is. That's boring. The interesting part is, what are we going to do? Now, how about Margaret Thatcher? So, why is Margaret Thatcher lying to us and slapping our hand and telling us, no, don't do this? Because you look at what this implies. This implies that we, with our little hands, could have had our representative with their hand write a number arbitrarily large as needed, as Vice President Biden said, to shape our society as we would like, with our hands. Now, when they slap our hand and lie to us and tell us you can't do that, who does that leave to shape our society? It leaves unaccountable people who get a say in proportion to the size of the stack of permissions that they have extracted from the rest of us in shares greater than their share. And there you have some of that agenda. Now, with that, pointing to some of the immense power that our vote has that we haven't thought about, I will hand it over to Lacey Watson and let him tell us a little bit about what it's like to be voted into office and more. Lacey?
Can everybody hear me? Perfect. So my name is Lacey Watson, and I am running to be the first African American congressional candidate from the state of West Virginia, located in the 3rd District. So if you are familiar with West Virginia, the 3rd District would be the lower 18 counties at the bottom of the state, starting with Mason and Cabell County on our far left, looking at the map, and ending with Pocahontas and Greenbrier County on our far right. A little bit of demographics about my district. I am 93% white with a median income of about $34,000 to $44,000 dollars per year. We have a high school graduation rate of 80% and a college graduation rate of about 20%. So that can give you a snippet of the demographic of my constituents and how important messaging was in relaying this idea of modern monetary theory as espouse the benefits of living in a democratic society. So what I did throughout my whole campaign effort was to make modern monetary theory simple enough for everyone to grasp it in a short amount of time. And from the results that I've had in my primary election, I was very successful in doing so. Pody gave you a more detailed understanding of modern monetary theory, but what I did in my messaging was relate that theory directly to opportunities and how we could leverage West Virginia's 3rd District to accept these policies and to move forward in a way that would allow the working class people of West Virginia some loosening of the, I think a perfect analogy would be the knee on the person's neck financially. So in my messaging, I started out with the basic definition of modern monetary theory as Pody detailed quite nicely. And from there, I worked that into a narrative I constructed concerning jobs. Issue for Southern West Virginia would be the issue of jobs and how do we create more jobs and how do we sustain the individuals that are living in our district in a meaningful way without incurring more debt on them. And I would say, yeah, just without incurring more debt on themselves. And what we found was that the individuals within the 3rd District, they are very open to the ideas and concepts of modern monetary theory and how that could be a positive impact. It's a second narrative to the narrative they have been given throughout their life, and it worked wonders. I would also say that what West Virginia needs now, as far as an understanding of economics, is a newer narrative, and modern monetary theory does that. And people, with this demographic that I have, are resonating with this message. And I think on a smaller level, given the parameters of the person delivering the message and the receptiveness of the audience, it is a viable option for West Virginians. And, I will keep on delivering this message as I go through the general election in order to really solidify modern monetary's place in our history as a state and, the overall running of the nation. I think that concludes most of my time right now. I would love to take any questions that you guys have, particularly about West Virginia and the messaging that I used to win over my population of people at the very end. But thank you so much for your time.
Thank you. And I think I'm up next, and I'd like to be able to share my slides. I have a few slides, and then I'll try to save as much time for us to have a Q&A session and a conversation. So I'll go ahead and start sharing my screen, and hopefully this will appear smoothly. Maybe Podio, somebody can confirm that you can see my slides.
Yes, we can. It's working fine.
Okay, wonderful. I'll try to make this full screen if Zoom lets me do it. Let's see. Okay, it's going to take a minute to load on my side. There you go. So the big question that everybody gets, you know, Democrats, Republican, anybody with a public policy platform to, you know, spend on healthcare, education, reparations, Green New Deal, the question is, how do you pay for it? And what I'd like to suggest today is that when we think about the US federal government, that is not even the right question, right? So let's dive into it based on what my two colleagues have proposed. First, I'd like to suggest that we don't shy away from being radicals. And I really insist on using the term radical and retaking the meaning of the term. We have deep structural problems, a climate crisis, inequality crisis, socioeconomic exclusion crisis, a dysfunctional political system, and the establishment is looking for incremental bipartisan solutions. In other words, we're looking for superficial status quo solutions. So why I use the term radical? I use it in the linguistic sense of the term. Radical means going to the roots of the problem. In other words, addressing the structural and the systemic change that needs to take place. The opposite of radical change is superficial change. So we really have to decide, do we want systemic structural change or superficial change? We can't afford the superficial change. I'm reminded of the words of Martin Luther King here, where he says, this is no time to engage in the luxury of cooling off or to take the tranquilizing drug of gradualism. This is exactly what I'm talking about, the tranquilizing drug of gradualism. We need radical systemic change, not superficial, you know, bipartisan change. The political establishment of our dysfunctional political system today is trying to convince us that we need incremental bipartisan solutions. That is the textbook definition of the status quo. And I think we all agree today that, you know, we're not looking for more of the same, more of the status quo. The Green New Deal in particular, to me, is about two major things. One is the inequality and socioeconomic exclusion crisis. The other one is the climate crisis, and they're interlinked. And I'm not going to show you a lot of data here, but I really wanted to show you this particular picture here because it's so important to what we're going through in this country. So to simplify the meaning of this picture, which is by my colleague Pavlina Cherneva, another MMT economist, what you're looking at here, the blue bars represent the bottom 90% of the population, and the red bars represent the top 10%, right? We don't have to go to the top 1%, just the top 10%. And what this picture is trying to show is essentially every time we go through a recession and we recover, this graph is showing us how much of that recovery, the wealth generated by the recovery, is going to the bottom 90% versus the top 10%. And it used to be the case a long time ago that after every recession, when we recover, most of the gains from the recovery go to the bottom 90%, which is the way it's supposed to be. And the top 10% get some of the gains, right? But then starting in the 60s and the 70s and accelerating in the 80s, most of the gains from the recovery started to go to the top 10%. And look what happened in the last recovery. Recovery, not the recession. This is the recovery when the recession is over. The top 10% gained more than 100% of the gains from the recovery, and the bottom 90% lost ground.
Dr. Kaboub, I'm so sorry to interrupt,
Yes.
but on our screens, it looks like you're stuck at the first slide and we haven't seen the last 3 slides. We can see them in little on your left-hand column, but people can't see the, slides. Okay, there we go. Thank you so
better?
much. Yes.
Okay. Sorry about that. So I'll just leave it like this instead of doing full screen. Since you didn't see it, I really want to give you a chance to look at what I'm talking about. So after every recovery, who gains from the recovery? It used to be the case, the bottom 90% gets most of the gains from the recovery, and the top 10% gets a little bit. And now we're looking at most of the gains from the recovery going to the top 10%. This last recovery between 2009 and 2012, the bottom 90% lost ground. And this is why most of you probably interact with people. Maybe you've experienced this yourself in 2012, 13, 14, 15. Most people around me were saying, well, it feels like it's still a recession. And it's because of this, because there was no recovery for the majority of the people, right? So we haven't done anything structural to undo this problem, which means as we recover, hopefully, from this crisis, I suspect that we're going to see this and maybe even worse in the coming years. So the Green New Deal is designed to undo some of these structural inequities that are built in the system by design. They're not going to go away just by, hoping for a better world. You have to actually actively implement policies. And now the question becomes, how do we pay for it, right? So a quick thing about the Green New Deal and how it addresses these things. Number one, it's federally funded. You can't have a Green New Deal funded at the local level because local, state, and state authorities and city authorities are limited in their spending capacity by the tax revenues that they get and by whatever the market allows them to borrow. So yes, they can get things done, but it's very, very limited. It doesn't mean you can't improve on energy efficiency. It doesn't mean you can't spend in the right way, to spend in the most neglected areas of the economy, the most neglected communities. Of course, you can do that at the city level, at the state level. But we're talking about the firepower of transforming an economy structurally. States and municipalities are not going to be able to do more than a little bit of, helpful patchwork. But the federal government at this point in time is the only entity that can do this structural transformative way. That doesn't mean the federal government decides everything. Federally funded, locally implemented in a decentralized way. This is really about reviving democracy, participatory budgeting, participatory selection of projects, participatory auditing, and everything that is about deciding what to do gets done at the local level. Everything that is about funding has to come from the federal government. It has to be urban and rural, right? And let's not forget about rural areas in the United States. It has to be inclusive. It has to be just. It has to be restorative. Inclusive in the sense that, you notice the name Green New Deal is a reference to the original New Deal, which was not inclusive. So let's not repeat the mistakes of the 1920s and the 1930s, and let's restore and introduce, a system that is, fair and equitable and that allows for shares prosperity. And it has to be just in the sense of a just transition. In other words, yes, we want to decarbonize the economy, but we don't want to end people's livelihood, right? So if we transition away from coal mining, we have to have a job guarantee that transitions workers to guaranteed jobs with decent wages and benefits, not decarbonizing the economy and forcing people to go look for jobs and look for training, pay for it out of pocket. So just transition is very important to the concept of the Green New Deal. And it has to be comprehensive and permanent. So we can't just do this for a few years and then hope that we've ended climate change or we've ended inequality. It has to be comprehensive in the sense that it's not just about solar panels and wind turbines. It has to be, transformative to the entire productive system, the way we consume and deliver and produce. We're talking about R&D in material science to make sure that everything we produce and consume and transport is done in a sustainable way, so that we produce a fully and truly circular economy moving forward. To me, the framework, the main framework for the Green New Deal is that we take people and the job guarantee, to be honest, which is a core component of the Green New Deal. We take people as they are, where they are, and we do on-the-job paid training with living wages and benefits. And we have to be, willing and able to offer a broader support network that includes housing, mental health care, legal aid, soft skills, family counseling, career counseling, to allow people to thrive on the job and to reconnect with the local community on a stronger foundation. To be honest, we can't just set people up for failure and say, we're going to offer you a job and it's going to pay $15 an hour and you got to show up at 8 o'clock. But what if I have mental health issues? What if I have family issues? What if I don't have any experience on the job? Then you're setting me up for failure. So when we say benefits, those benefits need to be inclusive of services that truly allow communities to thrive, and to build on a stronger foundation. In other words, we don't give up on people. In other words, we lift everybody up to higher grounds systematically, not hoping that things will happen. So the question is, how are we going to pay for this very ambitious program? We're told that the government is broke, we're running out of dollars, the rich will never pay taxes, the debt will burden future generations, and then you hear people talking about Zimbabwe and hyperinflation and Weimar Republic, and we're going to have to borrow more money from China. And what I'd like to invite you to do is, with this webinar today is to learn how to call their bluff when they say we can't afford this stuff. So my suggestion is to think about how we paid for World War II. World War II came after the Great Depression, the most miserable time in the history of the United States. There was no money to be taxed during the Great Depression. There was no money to be borrowed. And then we had to face this massive spending effort for the war after Pearl Harbor. And we didn't tax anybody before the war. We didn't borrow from anybody before the war. But we entered the war and we were able to spend massive amounts of money without bankrupting the country, without causing inflation or hyperinflation, and without having to borrow from China or Germany or any other country. Forget about World War II. How did we pay for the CARES Act? Right? 3 weeks before the CARES Act, every single person in Washington, D.C., you ask them, they say, we can't afford the Green New Deal. We can't afford Medicare for all. We have no money. And then all of a sudden, the pandemic hits, and they passed the CARES Act with $2+ trillion that were spent into existence out of thin air. Nobody said, where did that money come from? Nobody said, who did we tax? Who did we borrow from? Because the power of the purse is in the hands of Congress. They spend money into existence on all kinds of priorities. The priority 2 months ago, 3 months ago was to deal with the pandemic. The priority before that was funding the military. The priority before that was tax cuts for the rich. The priority before that was to invade Iraq. There's always a priority, and Congress is always able to meet it. Now it's time for us to send people to Congress, 535 representatives who know what the priorities of the people are, and to vote accordingly and spend accordingly. So we're talking about a paradigm shift here. So Congress has the power of the purse. Number one, Congress decides on the budget and how much to spend. So government budget is not the same thing as my budget or your budget. It's not a household budget. Government spending is not constrained by tax revenues, like at the city or state level, right? Cities need tax revenues, but the federal government doesn't need tax revenues in order to spend. Government spending is constrained by other things. Those things are mainly the risk of inflation. So the question becomes that spending capacity, or what we call the spending space that the government has, the fiscal policy space, is much, much larger than the tax revenue space that we usually think of. So what the limit is not tax revenues, the limit is the inflation risk, which is a much larger space. Inflation is determined by a couple of things. One is a productive capacity of the economy. In other words, do we have enough machines and tools and raw materials and skilled people to get things done? If we do, there will be no inflation. If we don't, then we're running out of materials. So the good thing about shortage of productive capacity is that it's producible. We get to produce more, we get to hire more people, we get to create millions of jobs. So that's doable, right? The other constraint is much more complicated, political in this sense. So the second thing that causes inflation is market power, where you have key players in the economy, like Big Pharma, like Wall Street, like big real estate developers, who can raise prices because they can, because they have too much market power, because Congress allows them to do so. Remember, the lawmakers, their job is to regulate the market. But in many cases, think of big pharma, think of insurance companies and so on. This is where inflation comes in. And that type of inflation, you're not going to be able to get rid of it by spending more or spending less. You get rid of it by taxing and regulating their market power out of existence. In other words, you make that market more democratic, you make it more, more competitive. And that's the job of lawmakers. And if lawmakers abdicate that authority and let the market rule, then we, the people, suffer the consequences in terms of inflation and suffer the consequences in terms of, you know, Congress telling us, well, we can't afford more of that because those companies are sucking profits to the top 1%. And if we give them more spending, they'll suck more of it, which is precisely what happens. Right? So the goals, once we understand this concept, number one, we decouple the concept of spending from taxing at the federal level, not at the city or state level. Cities need taxes, states need taxes, but Congress at the federal level, spending and taxing are two important functions, but they're not connected. It's not one that pays for the other. So we spend on national priorities, healthcare, education, infrastructure, the Green New Deal, whatever we as a democratic society decide are the priorities. We spend on improving productive capacity, on strategic areas of the economy. But then when it comes to taxing, we're not going to tax oil companies or fossil fuel companies because we need their money or their permission to fund the Green New Deal. We're going to tax them because we want to decarbonize the economy, right? We're not going to tax the ultra rich because we need their money or their permission to fund healthcare. We're going to tax them because we want to reduce inequality, because we want to protect democracy from oligarchy, because we want to reduce their power and influence in politics, their power and influence in the market system. Those are very important functions. It has nothing to do with funding healthcare or funding education. So by addressing those via taxation and regulation, we free up the spending capacity of the federal government to address the national priorities. Taxing Wall Street, again, not because we need their money to pay for education, but because we want to reduce speculation. We want to reduce their power and influence in politics, their power and influence in the economy, to reduce inequality, to reduce abusive market power. These are very important goals. And once you think of taxes and spending in this decoupled way, then you realize that we're not really thinking about redistribution, where money goes to the top and then we take it and redistribute it. We're talking about pre-distribution, where money is distributed the right way from the beginning, right? And this way, we don't have to think of redistribution and begging the rich to pay taxes. Many of my really progressive friends and colleagues are stuck in this vicious cycle that says tax this to pay for that. And I would like to invite you to think of this as a very dangerous and counterproductive strategy. Here's why. Because if we believe that our Green New Deal and our equitable society depends on tax revenues from the rich and from fossil fuel companies, from Wall Street companies, then as a matter of logic, then we want those companies to be even wealthier and richer and have even more income so we can tax a little bit away from them to get our little priorities. That's the wrong thing to do. We want to undo that power, not give them more power and more control over the national priorities. So let's think of decoupling these two things. Can we afford this, right? Everybody says, can we afford all of this? This is the wrong question. Can we afford these pictures? Can we afford what's happening to these children? Can we afford the fracking and the public health crisis that we're dealing with? Can we afford this? These are the questions. Can we afford the forest fires? Can we afford the floods in the Midwest? The problem is the narrative that dominates the public policy discourse when it comes to economic decisions is always focused on economic growth. And they back us against the corner and they say, well, if you want schools, if you want funding for your programs, the fracking companies are creating jobs, they're creating wealth, they're creating economic growth. And we measure economic growth with, I'm going to move this for a second. We measure economic growth by GDP, gross domestic product. That's what we call economic growth. The problem is this economic growth includes all kinds of things that reduce our quality of life. For example, every time we build a prison, GDP goes up. Every time somebody gets sick and goes to the hospital for breathing treatment or for cancer treatment or pays for a prescription for something related to pollution, GDP goes up and gets celebrated on TV. They say, yay, GDP goes up by 2%. It gets celebrated. The fact that there's an oil spill and we spend $200 million to clean it up, GDP goes up by $200 million, but that doesn't mean that's a good thing for society. So what some economists did is they took this GDP number and they stripped it of all of those negative things that actually reduce our quality of life. And then we get this, the genuine progress indicator. You see this line? This goes back to the 1950s. For at least the last 40 years, we have no improvement in quality of life in this country. No improvement. And this is why this narrative makes sense to the average person who's, these are the constituents you're trying to vote for your candidates, right? This is their lived experience. Their lived experience, they're not getting ahead. They just don't know why, because the narrative in the media, on TV, and every other politician is saying, we need more economic growth. And they say, fine, we'll support you for more economic growth. But what am I getting out of it? Nothing, right? So we need to change the narrative. And once we change the metric and say, what are the things that actually improve my quality of life? The list of investments will pop up immediately. And the Green New Deal becomes so obvious. So then the average person really understands that when you say, would you rather spend, a little bit of money for after school programs to inspire kids with music and theater and summer camps and science, or not do that because we think it's too expensive, we can't afford it. And then 10, 15 years later, deal with, a public health crisis, with the opioid crisis, or building more prisons. Would you rather spend money up front for clean energy to clean up the water source, or not do that because it's too expensive, and then 10 years later pay for cancer treatment for everybody in town? So what I'm suggesting here is that the status quo is too expensive. The status quo is unaffordable. What we're proposing, the Green New Deal, Medicare for all of these things are much, much cheaper and much more humane for obvious reasons than the status quo that we think is affordable, right? So it's about changing the narrative politically and in the economics profession to set the priorities straight. And I'll close with this. We have 10 years to go, 10 years to act. There is really no time for small incremental solutions. The climate crisis, the inequality crisis, poverty, exclusion, injustice, all of these things call for bold, radical, transformative actions. The current climate policies, the jobs policies are too weak, too slow, too expensive, and they don't even work. Economic justice and climate justice via a living wage Green New Deal are possible, desirable, and affordable. And with that, I'm happy to take questions and engage in conversation. And I know our time is short today, but please feel free to get my contact information from here. Feel free to engage with us and with other candidates who are running on an MMT platform, a Green New Deal platform, and with the MMT scholars and the social media platforms that you're connected to. Thank you.
Thank you so much, Fadl. And we will be going all day, and we've got an after party today. If you want to stay, if you want to pop back, you're absolutely welcome. And by all means, do keep in touch. There was one very simple question at the end. They asked, what do you mean, how do we pay for it isn't the right question? So both of us have kind of answered that. Do you want to take a stab at it?
Sure. So the way Congress pays for things at the national government is simply by, getting 535 people in Washington, D.C. They decide this issue is a priority, let's say invading a country, let's say a tax cut, let's say a Green New Deal. They vote, and as they vote on that bill, they include the budget that says, we authorize the U.S., Treasury to pay for this program. The contractors who get, their checks from the Treasury for building infrastructure, for teaching, for, doing whatever things the government decided to do. They take their check to their bank, they deposit it. The bank, takes it through, the back, channels. It ends up at the U.S. Federal Reserve Bank, which is the bank of the federal government. The Federal Reserve Bank will clear that check by crediting the account of the appropriate, company that was the bank and the company that was, doing the service for the U.S. government, and they will debit the account of the U.S. Treasury. That's as simple as that. We usually think of, spending, as something that, needs to be funded by tax revenues, which is true for you and I. You and I have to work hard and earn an income first, then we can spend. We can spend a little bit beyond our means by borrowing up to a certain limit, borrowing from a friend, from a bank or whatever. But that's it. Our spending capacity is limited by how much we earn and how much we can borrow up to a certain limit. States and municipalities too. Municipalities have to collect taxes. States have to collect taxes. They too can borrow up to a certain limit, but not beyond that, not much beyond that. But the federal government spends money into existence. The logic is the exact opposite. The federal government spends money first, then collects it in taxes. So it's not limited by tax revenues, but it's limited by how much actual productive capacity the economy can handle without hitting the inflation limit. So it's a tough pill to swallow. And what I'm explaining here about MMT, about federal government spending, is only for the sovereign. Don't try this at home. This will not work for you, right? This is only the US federal government can do this. States and municipalities, they have to spend responsibly. You and I have to spend responsibly. Otherwise we go bankrupt, right? But the federal government has zero risk of solvency. It can never run out of its own money, but it can run out of things to buy. If we, in the productive capacity of the economy, run out of things to sell, things to produce, run out of engineering capabilities or raw materials, that's when the federal government starts to cause inflation, when there is really not enough stuff to go around for the government to start bidding up prices and so on. So the right question at the federal level is not how to pay for it, but how to mobilize the resources to produce the things that the national government, that the democratic society wants to prioritize. So how to mobilize the resources, how to organize the political system, the economic system, so that we prioritize those things. And in other words, what we're describing here in the MMT framework is really not an MMT idea that needs to be applied by Congress. Congress already does it. They just have the wrong priorities, right? They prioritize tax cuts. They prioritize not regulating big pharma. They prioritize, military spending and other things. And we're saying, a government of the people, by the people, for the people, should elect 535 people in Congress to set the priorities of their constituents, not the super PACs that get them in office, right? Not the lobbying, groups that have other priorities, right? I mean, there wouldn't be lobbying if their priorities and our priorities were the same. There's no need for lobbying, right? But their lobbying is obviously very powerful to set up the system to serve their needs. And the data speaks for itself. This is not something new that happened 2 years ago or 3 years ago or 10 years ago. Money's been sucked to the top systematically for decades. And, chipping away at this problem left and right by saying, oh, let's elect this person, he's slightly better than the other person. But if that person doesn't really have a strategy for undoing the damage in a transformative way, then we're really wasting our time.
Great. Thank you so much. Unfortunately, we are out of time, but if Tommy is here, Tommy, collect emails. I've just put my email in the chat, and Susan is talking about a session at 6 tomorrow, perhaps come to the workshops later, but we've got to yield. We've got a 2-minute break while the next session sets up. So thank you all very, very much.
Thank you.
Thank you.